So someone wanted us to redo the Anisocoria one, but only in 5 minutes. So Anisocoria, not the same size pupil. You're trying to determine whether it's the little pupil that's the problem or is it the big pupil that's the problem. And so the first step is looking at the light reaction. If the pupil doesn't constrict, well, that's the big pupil that's the problem. If both pupils constrict, then it might be a dilation problem. If it's a dilation problem, the Anisocoria is going to be greater in the dark. If it's a constriction problem, the big pupil is going to be the problem because it's not constricting in the light. So Anisocoria greater than in the dark implicates the dilation. That's the sympathetic pathway. That could be a physiologic Anisocoria, which is normal, or it could be a pathologic Horner syndrome. In the Horner syndrome, the pupil isn't dilating because it has a sympathetic lesion, and you can watch the video on the sympathetic pathway and the Horner syndrome to find out more about that. But it's going to be an Anisocoria that's greater in the dark, and we can test that pharmacologically with aproclonidine, cocaine, or hydroxyamphetamine, and we're going to image the entire axis to determine what the cause of the Horner syndrome is. If it's the big pupil that's the problem, that's the Anisocoria is greater in the light, that is a parasympathetic problem rather than a sympathetic problem. And so that can occur in the nerve that is carrying that parasympathetic fiber. That's the third nerve, and so we want to make sure the motility and the lid are normal. Or it could be a problem at the junction between the nerve and the iris. And that problem at the junction is because you put drops in the eyes. That is pharmacologically dilated, like atropine or scopolamine from a scopolamine patch. That is a pharmacologic dilation that is blocking the junction. Or it could be a neurogenic problem, but at the ciliary ganglion, and that is Anisocoria pupil, or the postganglionic nerve. That causes the poor light reaction, but a good near reaction because of aberrant regeneration of the fibers from the ciliary ganglion that used to go to the ciliary body are now going to the iris, and so you think you're accommodating, but really you're constricting your pupil, and that causes light near dissociation of the pupil. That is the Anisocoria pupil. In addition, you need to do a slit lamp examination because we need to look at the structure of the iris, because sometimes it's a sphincter tear or synechii, or they've had surgery and there's some damage mechanically to the iris that's causing it to be atonic. It doesn't move for anything, or it's stuck down because it's got synechii, or you have uveitis or high intraocular pressure. So if you have a patient with different sized pupils, Anisocoria, the first thing is check the light reaction. If the light reaction is poor, that's the problem pupil. Then we're going to check in the light and the dark. If it's the dilation problem, it'll be worse in the dark. That limits it to physiologic Anisocoria or the Horner syndrome. If it's the big pupil, that's the problem. Third nerve palsy, motility ptosis, pharmacologic dilation, which we can test with pilocarpine 1%, which will not constrict the pharmacologically blocked pupil, or Anisocoria pupil, which you can test for denervation supersensitivity with 1/8% pilocarpine because of upregulation from the denervation at the ciliary ganglion, and you need to do a slit lamp examination to look at the iris.